And thank you everyone for being here on a Friday afternoon. Today we are going to have a little story time about Goldilocks and the three med lists. It's a polypharmacy story. I have nothing to disclose other than everything Lisa already mentioned about me. So we have just a few learning objectives to go over today. We'll start with explaining what polypharmacy is and how it frequently occurs. Then we'll move on to identify its impact in the long-term care setting on residents and our caregivers. We'll discuss some potentially inappropriate medications for older adults, and then also discuss a few strategies to deprescribe and reduce polypharmacy. So once upon a time, there was a nurse named Goldilocks. She had worked in several different practice settings over her years as a nurse, and never did she think that a long-term care setting would be where she ended up. But soon after taking the job, she realized she has a real passion in caring for older adults, and she spent the last 10 years or so doing so. Goldie's noticed something over the last few years while caring for her residents. Her medication pass on every shift she works seems to have gotten more complex. She has more medicines to give, even though she's still caring for the same number of residents on her hall. She finds herself contemplating, is this normal? Why am I seeing this change? Should I say something to the doctor about it or just let it go? What Goldie is noticing could be a topic that's been gaining more attention in healthcare recently. It's a phenomenon known as polypharmacy. So what is polypharmacy? Polypharmacy is defined as the use of multiple drugs to treat diseases and other health conditions. The most commonly accepted definition currently is the use of 5 or more medications. There's also a term for 10 or more medications, and that's known as hyperpolypharmacy. When we say medications and what's included in the polypharmacy bucket, it's all of their prescription medications, OTC meds, herbal supplements, and vitamins. So it's literally everything that they take. And it's not just a phenomenon that we're facing in the long-term care setting, but in the general population as well. What this means for us is that many times our residents are already on significant polypharmacy by the time they come to us in a long-term care setting. I'm sure many of you right now are already thinking, this is pretty much every single resident I care for. And you're probably right. There was a study done in the Journal of the American Medical Directors Association that indicated 91% of residents in a long-term care facility are taking 5 or more medications. And there are some known reasons for this. One of which is that we have a lot of new medications available. In the years 2020 through 2022, there are 140 new drugs that have been approved by the FDA. And those are the brand new ones. That does not include all the things that have gone generic and there are multiple manufacturers of, just the brand new ones. There's also been an increased focus over the last decade on preventative medicine, which has led to earlier treatment of many get on medications maybe earlier in their lifetime than they did previously. There have also been the creation or changes to clinical practice guidelines that reflect these treatments of a more preventative nature. So we're seeing more kind of step-by-step instructions on, if you have this condition, these are the things we would want to treat with. There's also tends to be a shift to more providers and prescribers involved in a person's care. And they each are prescribing different medications based on their specialty. We came from a place many years ago where we maybe had one general practice doc who was caring for a resident. And they didn't see a whole lot of specialists, particularly when they were in a long-term care setting. However, we're seeing a lot more referrals and a lot more specialists that have been brought in sooner, and so have an impact on that person's care. And we know that they're getting medications and supplements from various pharmacies or stores or family. And frequently, particularly if they're in the community, it's not known what all they are actually taking. And so you may be thinking, this is really normal and to be expected. And so why the concern? Well, while that may frequently be the case, there are many issues and concerns that can arise when somebody is taking multiple medications, particularly if they're an older adult. And so it kind of comes down to this concept of appropriate versus inappropriate polypharmacy. And this is a relatively new viewpoint on polypharmacy. So while many folks still define based solely on a number, more and more practitioners are looking at contributing factors that we discussed on the last slide. For many of our residents, because they have multiple medical conditions, they may benefit from taking 5 or more medications, and it may be completely appropriate. Actually, fewer medications, if it's undertreating, could actually be harmful. Our focus, we want to keep on positive outcomes and maintaining quality of life rather than just a strict number of medications. So why does it matter? We'll talk a little bit about the numbers. It's estimated that 40 to 50% of older adults experience polypharmacy. Due to the underreporting of those OTC meds and supplements, it's estimated that this number is actually probably closer to 67%. And if you break it down, it's about 44% of men and 57% of women that are 65 and older that take 5 or more medications. And then when you look at that hyperpolypharmacy, or those folks on 10 or more meds, it's about 12% of the population. And these statistics, keep in mind, these are the general population, not just our long-term care residents. As I mentioned a bit earlier, it's estimated that about 91% of our LTC residents are on 5 or more meds. We do have one advantage over many of those who are living at home with polypharmacy, and that's that we are actually aware most of the time of all the medicines our residents are taking, even if they're self-administering them, since everything requires an order. That does allow for our interdisciplinary teams to have the opportunity to catch some medication-related issues and possibly even prevent them. So the numbers clearly demonstrate that polypharmacy affects many of the residents we serve, but we want to talk a little bit about the real impacts that are a result of this, some of which directly affect our residents and their well-being, but there are also things that affect our caregivers and staff. So some of the impacts in real life are an increased number of adverse events and reactions, things like falls, fractures, cognitive decline, drug-drug interactions, and non-adherence or non-compliance with their medication therapy. To give you an idea on how this is affected, there are some studies that have tracked the number of medications and the occurrence of adverse drug events. And when someone's taking 2 medications, it's at about a 13% risk, but jumps up to about 58% once they're taking 5 medications. As you add each medication, you can expect probably about a 7 to 10% increase in that risk of an adverse event with each new medication. With 4 medications, there's a 50% risk of a drug-drug interaction occurring. And if you have 10 medications on board, that risk jumps to 100%. So if you're on 10 medications, you're guaranteed to have some sort of interaction going on with those medicines. It may not be a complete contraindication, but definitely something to be aware of, that maybe there's additional monitoring that needs to be done or a dose adjustment. A higher rate of errors that can occur. More medications, more med pass times. Obviously, there's an increased risk of errors occurring there. There's going to be an actual increase in cost. If you take more medicines, there's going to be more copays, or a larger amount once you reach your donut hole. So it results in out-of-pocket expense as well. And then when we look kind of just beyond the impact to our residents, there's an increase in emergency room visits, hospital admissions, and longer hospital stays related to polypharmacy. It was predicted back in 2019 that polypharmacy would result in 150,000 premature American deaths and more than 4.6 million hospitalizations over the next decade. And that 10 to 30% of those hospitalizations in older patients are directly related to a medication adverse event. So there is a real impact to our residents as well as the healthcare system. And as I mentioned, just in that statistic, there's an increase in mortality risk. And those overall healthcare costs could double. There's also the impact to our staff. So nursing or med tech time, with more medications and complex regimens, there's more staff hours that go into care. There's usually going to be additional monitoring, such as checking vitals more frequently. We have to check blood sugars, weights, maybe inputs and outputs, obtaining blood work, having, phlebotomists come in, draw labs. There's also additional paperwork, whether that's just our internal documentation processes, but also if there are these transitions with it's all of that results in paperwork that has to be done and staff time dedicated to doing it. And we know that each time you have to transcribe an order, there's an increased chance of a med error occurring. So what do we do about it, you might ask? Well, since most everyone we care for is experiencing polypharmacy, how do I know if it's appropriate if I should ask questions? So let's kind of talk through some examples here. It wouldn't be the story of Goldilocks if we didn't have a too few, a too many, and a just right. So we'll start with our potential case of too few medications. And this is DP. She's a 79-year-old female who lives in an assisted living community that Goldie works in. She has a diagnosis of unspecified dementia without behavioral disturbance, bipolar disorder, hypertension, hyperlipidemia, anemia, hypothyroidism, GERD, and insomnia. She doesn't have any allergies to medications, and she's not taking a whole lot of medicine. She takes lorazepam, 0.25 milligrams twice a day, rivastigmine, 1.5 milligrams twice a day with food for her dementia. She's got some PRN, acetaminophen, Senna, Vanafen, and guaifenesin. We do note her vitals on here. She's got a BP of 158/78, pulse of 57, and she weighs 136 pounds. We're going to take a look at some cases to help you recognize things. And so let's answer the question, is this an example of polypharmacy? Well, yes, indeed it is. She's taking 5 or more medications when you look at her prescriptions, her PRNs, and her OTCs and supplements. However, despite this being an example of polypharmacy, she's possibly undertreated. She's noted to have some active diagnoses for chronic conditions, which she isn't taking any scheduled medications for. That includes her hypertension, hyperlipidemia, anemia, GERD, and hypothyroidism. So while many perceive all polypharmacy as bad, that isn't always the case. We've learned a great deal about the value of preventative medication treatments. For example, we know treating high blood pressure can prevent heart attacks, strokes, and long-term effects, meaning the patient, or in our case, resident, stays healthier longer. This knowledge has led to the clinical practice guidelines we referenced earlier for several chronic medical conditions. And many times we find our older adults might not be maximized on these regimens. Sometimes there's valid reasons, such as a medication side effect or intolerance, or maybe that the time to benefit of the therapy is longer than maybe the resident's expected life expectancy. But many times it's not the case. So what are some questions or concerns that you have about DP's current medications? Well, some questions that I myself as a pharmacist would probably ask. Yes, I noticed somebody pointed out her blood pressure was on the high side. Good call, Carrie. First of all, I would maybe start by asking, should all these diagnoses still be active? Maybe some of them have improved or resolved over time. We know as we age, our needs change, our metabolism changes. Maybe her hyperlipidemia has improved now that she is maybe, since she's in a community, she's being more active. Maybe she has a more consistent diet. And so that hyperlipidemia is not an active diagnosis. Or maybe an offending medication has been stopped. So in looking at her past history, she used to take an NSAID, naproxen, twice a day, which could have actually been the cause for her GERD. And so now she may not have that GERD diagnosis anymore, and that could be eliminated. As Carrie pointed out, her systolic blood pressure was somewhat elevated on this month's check. So maybe this is something we need to monitor more frequently and consider treating if it remains elevated. Maybe we should ask the question if titrating up her rivastigmine could improve her anxiety symptoms. Maybe that would allow for tapering and discontinuing that routine lorazepam. We know that those benzodiazepines can contribute to sedation, confusion, and falls, particularly in our older adults. So maximizing that other treatment might actually be able to reduce some polypharmacy for her. And then, of course, it might be worthwhile to take a look at any labs done to assess her thyroid function, that anemia or hyperlipidemia, just to make sure that anything that is appropriate for treatment is getting it. Let's see, we've got a couple other comments in here. Not having thyroid med could increase her complaints of pain and lethargy, dry skin, and constipation. Yes, very true. So checking that TSH would definitely be a good idea at this point. And I agree, Sarah, the diagnoses are frequently not looked at or updated as often as they should be. Yes, it's particularly hard if there are multiple prescribers involved, because they don't necessarily see the whole picture. And that's why it's so important that our caregivers, our nurses, have the tools and understanding of what polypharmacy is, so that they can kind of raise those questions or bring important things to the physician's attention. So the next resident that really raises a flag for Goldie is NB, who is an 87-year-old female who's on the skilled nursing side of her unit. And we can see that NB has an extensive list of diagnoses. She has a MRSA infection of a right hip prosthesis that she experienced a few months back. She does have some unspecified dementia with anxiety. She's post-CVA. She also has a cough, pruritus, diarrhea, neuropathy, dry eyes, a candidiasis infection, historically, hypokalemia, constipation, osteoporosis, hypertension, vitamin D deficiency, insomnia, hypothyroidism, a history of an MI, and unspecified pain. She also has a few allergies that we'll want to take note of. Celebrex, an NSAID, Lyrica, meloxicam, which is another NSAID, Plaquenil, sulfa, and trimethoprim. And she has an extensive med list too. With the diagnosis list, that's not exactly surprising. So she's on a baby aspirin, some cephalexin indefinitely for that MRSA infection of her hip prosthesis, clopidogrel, some PRN Miralax, Culturel for that chronic antibiotic use. She's got some PRN Imodium on board, furosemide, levothyroxine, Metamucil, some oxycodone, scheduled dose, and also PRN, some potassium, Sarna lotion, Systane eye drops, routine Tylenol, Zyrtec at bedtime, some diclofenac gel to her knees, some PRN Senna, gabapentin for her neuropathy, sertraline for anxiety, and hydroxyzine, which is a relatively new order that was just started on 4/23. She's only used a couple of her PRN medications, so we don't have to be quite as concerned about that. Her pain rating is good. She's a 0, max out at 4, one time out of 10. BP's good, pulse 72, good, weight at 200 pounds. She does have some lab work available. Her CBC and BMP were within normal limits, and her TSH is 1.222, which is normal. So everyone probably already notices that there's significant polypharmacy in this case. She is a great example of what's a phenomenon known as prescribing cascade. And a prescribing cascade is when medications get added to treat the side effects or possibly an adverse reaction of another medication. Frequently, this can be avoided by going back and choosing a different medication for the initial problem rather than adding a new medication to treat the side effect. However, we know that this happens relatively frequently when we call a physician with a new problem. The natural response is to add a medication to treat the problem. So let's kind of highlight a few of the possible concerns with NB's polypharmacy med regimen. And she's got a few, potential flags here going on. She's got some possible allergies. She's taking medications in the same class as some of her listed allergies, and it's noted that she has allergic symptoms. The pruritus and dermatitis that she's experiencing could be related to this. She's got NSAID allergies. She's also got a sulfa allergy, that Lyrica allergy, and is taking diclofenac gel, furosemide, and gabapentin, and is having those allergic responses. We also have some similar medications on board. She's taking 2 medicines that work in a similar way. She's on 2 antihistamines to treat that itching and pruritus that she's experiencing. She's got the cetirizine or Zyrtec, and then that new order for the hydroxyzine. It's probably relatively safe to assume that the cetirizine, the Zyrtec, was not adequately treating that pruritus, and so they needed to add the hydroxyzine to her regimen. However, the Zyrtec still stayed on board. We have some competing medications. How many of you noticed that she's on medicines to treat diarrhea and constipation? So it's difficult to maintain a good balance if you're giving medicines for both. So she's got some Metamucil on board for diarrhea and then some PRN Imodium, but she's also got some scheduled Miralax and PRN Senna to treat constipation. So we're kind of competing with each other here, and that could be part of the swing of needing some of these PRN medications. She's got some Beers List meds. Beers List is also kind of known now as those potentially inappropriate medications for older adults, and she's got some medications on board that are included in that criteria. So she's on some baby aspirin along with the clopidogrel, which might not be a necessary combination at this point. Long-term antibiotic use, that's something that gets a little tricky because we've got some infectious disease involvement here. So something to keep on the radar, but not necessarily, just go and try to get rid of that, but something to be aware of. And then she's on this new chronic routine order for hydroxyzine, which is a highly anticholinergic medicine, and that's what lands it on that Beers List. And it also appears that she might be experiencing some side effects from her medications. So she's on Cystane for dry eyes. She's got Miralax for constipation. And with those antihistamines and the diuretic on board, those things could be related to those medication therapies. And last but not least, it wouldn't be the story of Goldilocks without all three. So our last example that we're going to look at is that of CG. And she's an 86-year-old female on that ALF side with diagnoses of hypertension, diabetes, Alzheimer's, dyslipidemia, heartburn, vitamin D deficiency, depression. iron deficiency anemia, seasonal allergies, peripheral edema, dry eyes, and a B12 deficiency. She does have a few allergies listed. She's got diclofenac, gabapentin, and latex. And her chronic meds, her med orders are enalapril 20 once a day, Lexapro for her depression, ferrous sulfate, which actually was just recently discontinued, Flonase for her seasonal allergies, some vitamin D, vitamin B12. She's got some refresh and lubricant drops for her dry eyes, just PRN, PRN Tums for her heartburn. And she did have a fairly recent order to start some Mobic, but that was discontinued. And instead, she's been started on some Tramadol due to her NSAID allergy. Her vitals are stable. Her lipid panel is good within normal limits, and her A1C is 5.4. So she's right there in that very ideal range. She's not on medications, but so we don't need to necessarily be quite as concerned with that since her A1C is good. Her vitamin D and B12 levels came in within normal limits. Her hemoglobin is good at 13.5, and that iron level was normal, which is what likely prompted the discontinuation of her ferrous sulfate recently. So as you can see from this example, there is polypharmacy. However, this is a pretty good demonstration of what might be considered appropriate polypharmacy. We can see that her chronic medical conditions have treatments in place. Medication monitoring is occurring, which is evident by the recent discontinuation of the iron in response to those labs and the correction of her anemia. And the potential allergic reactions are being avoided by changing those medications that are in the same drug class as her allergies. So, what are some things to look for? We talked through some of these examples, but just to kind of summarize here, medications that have no obvious diagnosis or an indication for use are kind of a standout thing. It is appropriate to ask if the medicine is still needed, and if so, what we're treating. As a caregiver or a nurse, how are you supposed to know if the medicine is working if we don't know what we're treating? Or maybe the diagnosis doesn't match with what the medicine is known to be used for. Sometimes this is just a transcription mistake, but it's something to keep an eye out for and either ask your provider or maybe talk to the pharmacist about it. Medication duplications, which is that same type or class of medicine used for the same condition. Allergies to medications, interactions with foods, meds, or disease states, those high-risk medications that fall on those beer criteria, but some that we know just from repetition, those opioid pain meds are things that we want to pay attention to, benzos, medicines for sleep, and antihistamines. And also any new orders that we may get to treat what is likely the side effect of another medication. You may be thinking that it's just too much, that if you aren't a doctor, a PA, a nurse practitioner, or a pharmacist, that you can't have any influence on polypharmacy, but that is not true. So here are some ways to kind of think about it. So those med duplications, allergies, and interactions, most of those are going to be identified by your pharmacy, and you'll get a call, which will probably be slightly annoying, but it's for a good reason. We'll call you about these concerns and bring them to your attention so that you can make the doctor aware. Many times, it's important to pay attention to what the actual concern is. Sometimes they're minor things, but sometimes they are really important. And it's always good to take a note, speak to the provider about the pharmacy's concerns. If it's easier for the pharmacist to speak with the doctor directly, they're happy to do that as well. We always just want to make sure that everybody in the system is kept in the loop and understands what's going on with the residents' medications. And on that new medicine to treat the side effect, If you notice a new symptom and you also are aware that a medication was recently added, that's a good thing to be a great big red flag for you. So when you call that doctor or provider, not only is it important to tell them about this new symptom the person is experiencing, but also just kind of mention that they were recently started on some other new medications, or maybe there was a recent dosage change. There are also some tools that you can use. So we've included some of these in here for you. I've referenced already the Beers criteria for potentially inappropriate medications in older adults. This is one of the more well-known and recognized tools available. There's start-stop criteria. Deprescribing.org is a helpful website, and it can break down individual medical conditions and kind of the best steps to take for deprescribing for those. The anticholinergic burden tool is basically a calculator. It can actually add up the anticholinergic risk for a person based on their medicines and kind of tell you where they fall on that risk scale. If they're on a lot of anticholinergic medicines, maybe they're just on one that's really highly anticholinergic, but it can kind of give you that range to know where you're going to fall on that scale and whether we need to look at kind of reducing that burden for our resident. And then there's also medstopper.com, which is a place you can put in their medications, and it will look at the person's frailty and kind of address some areas to pay close attention to. But as I mentioned, the Beers list is the most recognized and accepted curated list of these types of medicines, and it's updated every few years by the American Geriatric Society. And we lucked out because just last week, they released the latest updates, so that was good timing. So we'll just mention a few things that about the Beers criteria here today. It's extensive. There are 5 different tables included in the Beers criteria. The first one is probably the one we reference most, and that would be most useful to our caregivers on the call today. And those are those medications that are considered potentially inappropriate. The abbreviation for that is PIMS, potentially inappropriate medications. Then there's the second table that is medications considered inappropriate if the person has a certain disease or condition. There's a third list that are medications to be used with caution. Then there's potentially inappropriate drug-drug interactions, and a list of those medications whose dosages should be adjusted for renal function. To hit some of the highlights for you here, there's some common medications that we see used a lot that are on this Beers list, this Beers criteria. Older antihistamines are some of them. That would be your diphenhydramine, hydroxyzine, which was on our one case, meclizine. Those are highly anticholinergic and so can have a lot of side effects for our residents. Nitrofurantoin, there's risk of several different types of toxicities with that. Digoxin is on there as a first line treatment, mainly because there are new, safer, and more effective alternatives. So we wouldn't expect somebody with a new diagnosis to probably be started on digoxin. That doesn't mean that we won't see it in people who have been on it long term already, but we wouldn't expect a new diagnosis and new treatment with that. There are certain antidepressants on there. Those are mostly because they are highly anticholinergic as well. The antipsychotic medications remain on there due to the black box warning of the increased risk of stroke and cognitive decline in persons with dementia. Those benzodiazepines are on there due to the risk of dependence, but also those side effects of sedation, delirium, and falls in older adults. The Z-drug hypnotics, which are similar to those benzo effects, that's your zolpidem, which we see frequently. Sliding scale insulin is on there, and sulfonylureas due to the risk of hypoglycemia in our diabetics. The extended use of PPIs, so your omeprazoles, which we see regularly, and that's that risk of C. diff infections, possibly pneumonia, and they also can cause bone loss and fractures. And then muscle relaxants, again, are because of that anticholinergic effect that they have. They have kind of made it a little more specific that it's when used for musculoskeletal pain and not the spasticities. So we will see it sometimes for that, but when it comes to treating kind of general pain, that's not kind of the first direction we want to go in. Now, this is not an exhaustive list by any means. It only kind of pulls out a handful of those medications on table 2 that we see a lot. The link to the full update is on the sources slide at the end of the slide deck. So if you'd like to take a look at the larger listing, I encourage you to go ahead and give that a look. We also have here a nurse's resource for you. It's really tiny. I apologize for that. It was hard to get it all on here, but there is the link here for you to go to, and it was put together by the American Society of Consultant Pharmacists. It's kind of a deprescribing basics, gives you some simple questions to ask. Also includes some different resources on there that you can go to, but kind of walks through the process of what to think about and maybe what the deprescribing process would look like for you. I encourage you to start simple. And, there are a few ways to identify these folks that might be good candidates for, trying to reduce their polypharmacy. First, you can look at your residents and actually find those people who have the most number of medications to see if there's anything that can be deprescribed. Frequently, as things get added over time, things just don't ever go away. And there can be simplification that occurs just on the number of medicines. Take notice of your residents that complain about taking too many pills. We all have them. Or the family member that's concerned about potential side effects or maybe a recent change in their loved ones. Those are good folks to kind of take a look at that med list on. Maybe that resident that you're in the room several times a day doing a med pass, giving them medication. Maybe there's a way to simplify. It may not even be completely eliminating the medicine, but there may be a more efficient way to dose it or administer it so that we can minimize those number of med passes. And of course, when there's a concern raised about cost, that's always a good time to kind of view the med list and look to see if everything on board is still absolutely necessary or if there are some steps we can take. So I've tried to include a few tips in here for success. Probably the first one and most influential one possibly is to get buy-in from the resident, from their family or responsible party. It needs to be something that the entire team is involved in. If your resident does not want their medications taken away, it really is not going to matter probably in the long term what we are able to get changed or reduced for them, because they will just they will feel the need to get it added back. So getting buy-in from the resident themselves, whether that's, something that can help them, maybe they're experiencing a side effect or complaining about something, and we can say, hey, maybe we can help if we adjust this medicine for you. Maybe they don't like having to take all the medications, and we can talk about things that we can eliminate with them. Of course, engaging other members of the team and having buy-in there is important. So whoever the provider is in your community, engaging the pharmacist, whether it's a consultant pharmacist, depending on where you're at, or even your dispensing pharmacist has knowledge of things like interactions and appropriate dosing of medications. There's a psych provider. Obviously, engaging them is very important, particularly if we're using a lot of those psychotropic medications, and even therapists. They can have some input into things that, may help the person be more active and be more successful in therapy. Sometimes reducing medications will actually help the person to be more active and more engaged in therapy, as well as social events and things like that. Starting small. This is a big one too. Make one change at a time. That way it's easier to identify your successes or even those things that don't work. But if we go through and start eliminating 4 or 5 medicines at one sitting, we're not going to know which things, were really a positive change for that resident, or things that maybe didn't work so well for them. And it's better to have to just add one thing back rather than have to go back to where we started and then start subtracting one thing at a time. And it can be as simple as just cutting out maybe 1 dose a day, or reducing the strength of something that they're taking. Small steps are still steps. So it's okay to do one small thing at a time. Monitoring and documenting, keeping track of any attempts to change or reduce medications and noting those outcomes. We don't obviously want to keep reducing a medicine if we know that it has a negative impact on our resident. But we also know that if it's not documented, it didn't happen. So we want to make sure that we keep notes on that. That way, also, if you're on first shift and the physician changed an order, we want the rest of our shifts to know that this was intentional and that there's a reason. And so if the resident comes to them later that evening and says, well, where's my medicine? We want the entire team to be on board and understand why the changes were made that were made. And last but not least, stay positive. Sometimes it's hard. Not every change or reduction will be a great success, but that doesn't mean it isn't worth trying. What works for one of your residents might not work for another. Remember that your end goal is to find that best possible regimen for that individual person. It's not going to be one sweeping action across the board for everyone. So keeping that really person-centered, resident-focused is going to be important. And so a final thought for our nurse Goldie and all of our nurses out there: small steps leads to big success. You can do it one small step at a time. And that is the end of our fairy tale and our story of Goldilocks.